In this video, I'm going to explain to you how interventional radiologists can help patients with knee osteoarthritis. Knee osteoarthritis is a very common condition, especially in the elderly, and it happens when the cartilage in the knee wears off and essentially your joint is not working as well. It's basically wear and tear in the joint. Traditionally, knee arthritis is initially treated with conservative measures like physical therapy or injections like a steroid injection or injection of PRP or hyaluronic acid. But these injections only go so far, and ultimately, the best way to treat knee arthritis is with a knee replacement. A knee replacement is a big surgery that has a long recovery time and requires a lot of physical therapy. Also, some patients may not even want a knee replacement, but some patients may not even be candidates for a knee replacement because they are too old or they have multiple medical conditions. And that's when we start thinking about some minimally invasive options. And I've been doing interventional radiology for almost 20 years, and I haven't done anything for knee arthritis until about 5 years ago when two procedures came to the spotlight. One is called Genicular Artery Embolization, and the second is called Genicular Nerve Ablation. Genicular artery embolization became interesting to physicians because they realized that there's a lot more to knee arthritis than just cartilage damage. There's also a lot of inflammatory changes that actually make the damage in the cartilage worse. Think about anything that is very inflamed, it's red, swollen, and painful, and that's usually related to a very high blood flow to that area. So this procedure started in Japan and has proven to be fairly successful in controlling pain in knee arthritis. The way it's done is we insert a 2mm catheter, usually to the groin, either the same groin or the opposite groin that we're planning to treat. We then navigate the catheter all the way to the knee joint, and there are several arteries going to the knee joint, and we try to find all of them. We then insert an even smaller catheter into these arteries called a microcatheter, and through this microcatheter we can inject these small beads. They're small spheres, microspheres, that will block the blood flow going to the knee joint. The results from genicular artery embolization are not always immediate, and sometimes patients may take a few weeks to start getting better. But the main advantage of this procedure is when we achieve good results, these results are usually durable and can last for a year, 2 years, or even more. Although the risks are small, like any procedure, there are some risks involved, including a risk of a bleeding complication in the puncture site and a risk of a nerve damage that is usually temporary, and it's really, really rare. The other procedure we can do, it's called the Genicular Nerve Ablation. It's a different spin on the topic. So there are essentially three main nerves that are going to the knee joint: the superior medial genicular nerve, the superior lateral genicular nerve, and the inferior medial genicular nerve. All innervate and are responsible for the pain around the knee joint. They don't have any motor function, so they're nerves that are not completely necessary and they can be ablated. Now, the nice thing of genicular nerve ablation is that it's a procedure that can be tested before we actually perform the procedure. The way we test is with a temporary nerve block. So we put the needles where the genicular nerves leave, and then we inject a temporary anesthetic that will last for about 3 days, and that can give you a good idea if this procedure is going to be effective for you. Now, if this procedure doesn't work, we can try the genicular artery embolization, or we can try some other procedure, but if it is effective, then we'll bring you back at a different date and we'll proceed with a more permanent ablation using radiofrequency. The way it's done is a special radiofrequency ablation needle that is introduced in the same position that we tested, and then it's connected to a machine that will essentially burn these nerves. Although traditionally the effects are not as durable as the genicular artery embolization. On average, the patients get relief for 6 months to a year, but this procedure can be repeated as many times as it's working. The good news is none of these procedures burn any bridges. So if they don't work, or if they worked and then they stop working, you can always have a knee replacement later. It doesn't make the procedure any more difficult or make you less good of a candidate for a knee ablation. Sometimes we do these procedures even if the patient wants to have a knee replacement but wants to get stronger before the surgery and needs to do physical therapy. So we can do some of these procedures so your pain can improve, you can get physical therapy, potentially lose some weight so you can be more fit for the definitive surgery. This is Minimally Invasive Insights, and I'm Dr. Fabio Komlos.